All right. We're up to 23 participants and it's 9:05, so I'll go ahead and get started. Good morning, everyone. I'm Carrie Bearden. I'm a professor in psychiatry and in psychology, and I'm going to be introducing our speaker today. Before we get started, a couple of housekeeping notes for the seminar series. I wanted to let you all know that the chat is disabled in this webinar format. So if you do have questions, you will put them into the Q&A. If you can see that little box on the right-hand side on your screen. And so if you have questions, feel free to put them in the Q&A throughout the talk. And then we'll have an ample time at the end for answering any of the questions that you have. So I hope to have, we can have a really lively discussion at the end of the talk. So with that, I will go ahead and get started with the introduction. So today I am really delighted to introduce our speaker, Bernalyn Ruiz. Bernalyn is a clinical psychology intern working with us in the adolescent serious mental illness track. And she's a PhD candidate at the University of Massachusetts in Boston, where she completed her dissertation, which is focused on a sports-based therapeutic intervention. And Bernalyn really has an interesting background as she's a former teacher. She completed her master's degree in clinical psychology at the Teachers College at Columbia, where she worked with Dr. Larry Yang at the Mailman School of Public Health at Columbia on research focused on cognitive functioning and schizophrenia, and also stigma in youth at clinical high risk for psychosis. And a fun fact, Larry Yang is Andrew Yang's brother, for those of you who've been following the presidential election, the big proponent of universal basic income. So I'm a big fan of both the Yangs. In Boston, Bernalyn completed her clinical training at Harvard's Judge Baker Children's Center, the Cambridge Health Alliance, and Massachusetts Mental Health Center, and Beth Israel Deaconess Medical Center. And Bernalyn is a Cal Berkeley grad, like me. That's where she did her undergrad. Go Bears. And so Bernalyn really impressed us all just so much when she came for her internship interviews with her enthusiasm, her passion for intervention for serious mental illness. And we have just absolutely loved having Bernalyn on our team. And I'm really excited for her to be able to have this opportunity to present to you about some of her work. So without further ado, thank you, Bernalyn, for presenting today.
Hi, thank you. Thanks, Carrie. That was really kind of you to say. And yeah, I'm excited to have this opportunity. So I will start sharing my screen now. Hopefully this shows okay. Okay, so yeah, so thank you all for being here ahead of a holiday. I'm sure that everyone is really ready for a well-deserved break. So today, as the title suggests, I'm going to be talking about stigma and coping strategies in individuals at clinical high risk for psychosis, specifically among Latinx and non-Latino white individuals. I've added to the title the popular phrase by Dolores Huerta, si se puede, which translates to "it is possible" or "yes, you can," a commonly used empowering phrase in Mexican culture. And also listed here are the co-authors and collaborators on this project, without whom this work would not have been possible. And just a special thanks to my mentor, Dr. Lawrence Yang, Christopher Ceccolini for his help in the analysis and writing of this project, and Dr. Bearden for her advising in the preparation of this presentation. And yeah, just a reminder that you can submit your questions throughout the presentation and we'll answer them at the end. And also, I don't have anything to disclose as part of this presentation. So today, my hope is to provide some understanding of stigma and its effect on people with psychosis, with a focus on those at clinical high risk for psychosis. In addition, I hope that we can walk away today having an awareness of stigma and coping strategies in the CHR population, particularly Latinx patients, as well as value the impact that stigma and various types of coping can have on these patients. And lastly, I hope that we can come to identify some ways that we can begin to adapt our clinical practice, given what we will be reviewing today. first, an introduction to the population that we'll be talking about. Clinical high risk for psychosis, or CHR, describes a label created to identify and treat individuals who show potential risk for developing psychotic disorders. We know that symptoms tend to appear gradually. Typically, you might first see negative symptoms like a decrease in emotional expression and avolition, and then cognitive symptoms, followed by the more commonly recognized positive symptoms or hallucinations and delusions. The CHR label includes 3 categories. There's the brief intermittent psychotic syndrome, or when an individual has psychotic level symptoms that are very brief or intermittent and last at least 1 month. The attenuated positive symptoms syndrome, or having attenuated positive symptoms of sufficient severity for the past month, and also probably the more common category to be met in this population. And then there's the genetic risk and decline, when an individual has genetic risk for schizophrenia spectrum disorder, and there's been some functional decline. And this is all typically determined using the structured interview for psychosis risk symptoms. And now I want to direct our attention to the image that we have here. This is useful for understanding what period we're talking about today. So the red box here highlights the risk period prior to a first episode of psychosis, where you might see changes in cognitive functioning, negative symptoms, positive symptoms, some of those start to happen. And so just highlighting that this is the period before a first episode of psychosis. And I also want to take a moment to specify here that I will use the term clinical high risk, or CHR, and specifically not prodromal, because the prodrome is a retrospective label. And not all individuals who are identified as high risk actually go on to develop a psychotic disorder. In fact, the majority of individuals do not convert to psychosis. I think current rates, or the last I checked, were about 20 to 30% of those in our clinics go on to develop a psychotic disorder. Okay, so treatment for this population can include individual therapy, group therapy, medication if necessary to treat the psychotic symptoms, or more usually to treat anxiety and depressive symptoms. And we've also seen some benefit for the use of exercise as well as nutritional supplementation. And despite the treatment benefits to early identification that we've seen, there's still stigma associated with the label, and we see that it is rooted in the stigma surrounding severe mental illness. We know that internalizing negative cultural stereotypes about mental illness is associated with negative psychological and social outcomes for those with psychosis, and can even increase risk of transition to psychosis and negatively impact mood. This 2015 study by Yang et al. And other collaborators on the research being presented today determined that shame related to the symptoms patients experience is associated with depression, and shame related to the risk label is associated with anxiety. So research has demonstrated that internalizing negative stereotypes is associated with schizophrenia among minority individuals. And then within the CHR population specifically, stigma has been found to present as a stressor that increases risk of transition. In the particular study cited here, they looked at cognitive appraisal of stigma-related stress as a predictor of transition to schizophrenia, and found that those who converted to schizophrenia had higher levels of stigma-related harm and stress. Again, suggesting that stigma stress may increase risk of transition to schizophrenia. And so we've seen efforts to address and mitigate stigma. And as you all know, it's an important part of our treatments, especially with individuals with schizophrenia spectrum and psychotic disorders. Some interventions have incorporated psychoeducation to address stereotypes with patients in treatment, such as family-focused therapy, developed by our own David Miklowitz. So shout out to David, which is now being tested in the CHR population under the leadership of our Carrie Bearden and David. In addition to, there's also been anti-stigma campaigns, and international efforts to come up with destigmatizing labels. For example, in Hong Kong, there was a campaign to change the name of schizophrenia from the original or more traditional name that translate to mind split disease to thought and perceptual dysregulation. And just as an aside, in my, anecdotally in my own work, I have found when talking to individuals of Chinese descent or who grew up in China, that describing the symptoms themselves is more not only descriptive, but also less stigmatizing than the use of the label. Which is kind of interesting. And we want to highlight that we do not endorse the use of race to explain disparities. Rather, disparities in psychotic disorder diagnoses based on racial divides reflect larger social divides in access to care, resources, and lived experiences. In this particular study, we were interested in looking at how experiences of stigma and coping might differ or be similar between ethnic groups. And so we looked at those of Latinx ethnicity, which refers to values, customs, or traditions to illuminate cultural phenomena on our constructs of interest. So there was a review of the literature which found that Latinx individuals are disproportionately diagnosed with psychotic disorders, approximately 3 times higher compared to non-Latino white individuals, and minorities are minors are twice as likely. Also important to note that we've seen that just generally immigrant racial minority consumers receiving mental health services may be assigned a psychotic disorder diagnosis more frequently than Native consumers with a majority racial background. In addition to rates of psychotic disorders, there's an increasing rate of mental health concerns among Latinx populations. We see lower mental health literacy, greater stigma, and lower lifetime prevalence rates of behavioral health services, or service use compared to non-Latino whites. And also the relationship between ethnicity and lifetime history of behavioral health service use has been found to be mediated by personal stigma. And of course, we also know that psychotic disorders are highly stigmatized and stereotyped, compounding the risk of stigma for Latinx individuals at clinical high risk. So to our knowledge, no study has directly examined Latinx experiences of stigma and discrimination related to the clinical high risk for psychosis label and symptoms. Because Latinx populations face higher rates of discrimination and stigma generally, there is potential for increased risk of transition to psychosis. We examined stigma experiences and related coping strategies of Latinx individuals identified to be at clinical high risk for psychosis. And also hoping that identifying possibly unique experiences and coping responses may provide insights to inform how to address stigma associated with the CHR label and symptoms with Latinx patients. Okay, so how did we go about doing this? So we interviewed help-seeking individuals at the Center of Prevention and Evaluation, or COPE, in the New York State Psychiatric Institute of Columbia University Medical Center. The SIPS was used to identify patients, and patients who met criteria per the clinician's evaluation were then referred to our study. We also collected self-report sociodemographic data and used a semi-structured qualitative interview focused on stigma and coping. And to analyze the data, we had 4 individual coders, all supervised by Dr. Lawrence Yang, and we held weekly meetings to reconcile differences. So our analytic approach, we used a deductive thematic analysis. For this particular study, we were interested, again, in the constructs of stigma and coping in varying ethnic groups, and the aim of the study was on stigma, discrimination, and coping response within the clinical high-risk population. Okay, and just a note on a researcher positionality, and to highlight that the initial team of coders was made up of diverse individuals listed here, and they're all authored on this paper that has been submitted. So myself, Bernalyn, sorry, one moment. Yeah, so as is practice in qualitative research, in bracketing our bias, these are the relevant positions of each primary researcher on this project. So myself, I'm a cisgender Latina with experience with mental health services, and at the time of this analysis, a student in clinical psychology. And the second author, Christopher, is a white cisgender male, a mental health care worker, and also a student in clinical psychology. So to get at the constructs of interest, we asked the following questions in a semi-structured interview, and these were all developed in collaboration with Stigma experts. So first question, is there anything that happened to you in terms of how people treated you, good or bad, as a result of being in this clinical high-risk program? We might follow up with, can you give me an example of when you were treated this way, who treated you this way, where and when? Second question, in being in this program, you have been told you have an increased risk of psychosis compared to your peers. So disclosing the CHR status. How has this affected how you see yourself and how others see you? And follow-up probes of how did you first react when you were told you were at risk for psychosis? And did being told you were at risk for psychosis change the way you thought about yourself? If so, how? Are you concerned about how others might react to knowing your at-risk status? Would others treat you any differently? And are you concerned others might think differently of you? So our constructs of interest, we use Jones' 1984 definition of stigma as an attribute that links a person to an undesirable characteristic. And stereotyping we defined as occurring when the dominant cultural beliefs are linked to a labeled person, defined by Bruce Link and Joe Phelan. Discrimination we also defined as using Link and Phelan's work. Structural discrimination occurs when accumulated institutional practices work to the disadvantage of a minority group. And individual discrimination occurs when one person's labeling and stereotyping of another leads them to engage in overt discrimination towards the other. Coping responses are strategies to manage stigma and typically referred to secrecy, withdrawal, and empowerment. Secrecy is the active concealment of symptoms and treatment to avoid rejection. Withdrawal involves limiting social interactions to hide the stigmatized condition. So you might see the individual spend, retreat from social interactions, spend less time with friends, less time with family members. Empowerment is defined as when the individual feels empowered by knowing their mental illness status and then educates others in hopes of teaching them about their condition to ward off negative attitudes. So yes, on to what we found. So in total, we had 20 interviews, 9 self-identified non-Latino whites, and 11 Latinx. They ranged from 12 to 27 and were mostly male. Okay, so onto the themes that we identified. Both groups described experiences of internalization of stereotypes. So internalization occurs when stereotypes about people with mental illness are adopted by our patients. Interestingly, the experience of internalization seemed to be more salient for non-Latino whites than Latinx participants. The non-Latino white patients expressed concerns of going crazy and that others wouldn't want to be with a person who has been singled out for this. And so we have a helpful quote to illustrate this. I don't know what's going on in other people's heads. I would worry a little about someone around me who is going to develop psychosis. My friend from high school and college developed paranoid schizophrenia. It's hard not to be cautious when having had this experience. I wouldn't blame anyone else for having these thoughts. Okay, so still within the theme of stigma, one of the sub-themes that we identified anticipated rejection from stereotypes. This captures patients' expectations of being treated differently because of their mental illness. Latinx patients reported anticipated rejection from stereotypes, seemingly more often than non-Latino whites. For example, one participant shared that they would not tell others about their mental illness because they don't want others to think I'm weird or different. They will laugh at me like I'm crazy. And others chose not to tell others because of ignorance or that others might not know what they're really experiencing. And so another helpful quote, there's no way I would tell others that cope is associated with psychosis. I don't want others to think I'm weird or different. They don't understand. And maybe they will think something about me, talk about me behind my back, laugh at me like I'm crazy or something. So we saw that clinical high-risk participants described experiences of individual, structural, and interestingly, anticipated discrimination. So describing hiding their illness or being wary of telling others about their experiences because they expected or anticipated being stigmatized and treated differently because of their mental illness. In highlighting the varying experiences of ethnic groups, it's an interesting observation that Latinx patients appeared to more often describe experiences of discrimination based on their mental illness status. Okay, so broader theme discrimination, sub-theme anticipated discrimination. Non-Latino whites described worry about how others might treat them differently and potential negative effects on job seeking. An example we see here is, I should be careful what I tell who. If I try to get a job or get a date, it's negative. My dad feels even more strongly I shouldn't let other people know. Whereas Latinx participants felt that others would exclude them, have negative thoughts about them, and their job opportunities would be negatively influenced. Other peers may think I have schizophrenia, especially people I don't know. These kids would then talk to other kids, they would misinterpret my condition and stay away from you. And another sub-theme within discrimination, individual level discrimination. Latinx patients described having experienced discrimination as a result of their mental illness status. And once more, this phenomena appeared to be more apparent among Latinx patients. So we have an example here. One coworker wants to know what I did and where I went. I didn't want to explain for myself, so this person doesn't talk to me as much. My peers misunderstand me. Structural level discrimination. So this sub-theme captured report of having experienced discrimination or negative effects within a system, such as a mental health system or in the workplace. Again, both groups reported having this experienced, but only one non-Latino white participant expressed this, stating most doctors won't ask about psychotic symptoms. Doctors won't recognize these symptoms in young people. They see it as teenage angst and react with eat your Zoloft. An example from a Latinx patient, Army people also said I was weird. They would go out of their way to make me feel different. Others in the Army knew I got psychiatric treatment, that they were planning to throw me out as a result. So our next theme, or our next major theme, coping responses. Within the coping response theme, sub-themes that stood out were secrecy, covering, and empowerment. Non-Latino whites most often used covering, while Latinx patients seemingly used secrecy and covering similarly. And interestingly, we observed that Latinx participants utilized a greater variety of coping responses, including empowerment strategies. So both groups utilized covering. Covering refers to finding ways to hide the use of mental health services. For example, they might tell their friends that they were coming up to do research or to volunteer on projects. Non-Latino whites primarily used covering. One example we see here, I told two friends from high school and also my mom and dad that I did a research study involving emotional testing and behavioral things. I told them I was at a research program. They said, it's good that you have something to do this summer or during the summer. So we found that secrecy is a very commonly used coping strategy for clinical high-risk patients. For Latinx patients, secrecy seems to be one of the most salient coping strategies. As this patient shared, I would never tell my workplace because I would then lose the protection from the certificate of confidentiality that I am offered from COPE. Non-Latino whites also expressed secrecy or using secrecy strategies, particularly towards family members. So we have here, initially I was under the impression that mental illness is not something you talk about. In my family, it wasn't something you wanted to acknowledge. People ignored it. Okay, so a different theme, empowerment. So within coping responses, we identified empowerment strategies. So clinical high-risk patients described using empowerment coping strategies. This includes feeling empowered by knowing one's mental illness status, receiving care, challenging others' stigma or negative attitudes towards people with mental illness, and educating others about mental illness and mental health treatment. Of interest, empowerment not only captures the individual feeling empowered, but also their family members or caregivers. One of the more interesting things that we noticed was that this appears to be more often utilized by Latinx patients. One participant described having a direction, and others shared that their family members responded by feeling empowered to advocate for their care. So we have helpful quotes here by Latinx patients. This being identified as at risk for psychosis gives you a direction. I know what to focus on. I'm getting ideas and theories because of my experience with psychosis. Another patient shared, I was only discharged from the hospital because my parents supplied COPE as a place I would see continuing care. All right, so moving on to what does this mean? So again, we looked at differences among CHR patients' experiences with both the label and symptoms, with a focus on concerns about stigma and coping strategies. Consistent with previous work, both groups showed high rates of internalized stereotypes or reported experiences of internalizing stereotypes. However, Latinx patients appeared to describe more anticipated rejection due to mental illness status and service use, and more experiences of discrimination due to their mental illness status. We saw that these Latinx patients engaged in secrecy and covering as coping, but in addition, they also engaged in empowerment strategies. So this is important because previous research has shown that having more experiences of discrimination due to your mental illness status is related to an increase in anticipated discrimination and more internalization of stereotypes. That kind of makes sense then, right, that our Latinx individuals reported anticipated discrimination and internalization. And so we were wondering why internalization seemed to be more salient for non-Latino whites. And we think that this could be perhaps due to more exposure to mental illness among non-Latino whites compared to Latinx families, because we know from research that Latinx families tend to avoid discussing mental illness or feel that it's not something that you talk about. Overall, the findings support existing theories that greater anticipated discrimination results in more anticipated stigma. So because of the negative consequences of secrecy, mental illness stigma can contribute to suicidal ideation. This then, combined with the cultural tendency for Latinx persons to not talk about mental illness, is concerning and should be addressed in treatment. We wonder if Latinx patients perhaps initially utilize secrecy as a result of internalized and anticipated negative stereotypes, but if they can then get to a point of disclosure, then they are likely to utilize empowerment strategies such as educating others or advocating. And this finding presents a paradox in coping strategies utilized by Latinx patients at clinical high risk. And future research should continue to elucidate the possible mechanisms by which patients may access and enhance empowerment-based coping strategies. We also want to highlight that this finding reveals a positive characteristic shared amongst Latinx patients. That is, rather than a mental health challenge causing division, the families and friends of a patient rally together. And this reminds me of this aspect of Mexican culture where people will come together when faced with great challenges. Certain events in Mexican history come to mind, such as the Batalla de Puebla, which we celebrate on Cinco de Mayo, where the small Mexican army beat the large, more powerful French, and sort of remains a staple of Mexican culture and pride. And the United Farm Workers Movement, led by Cesar Chavez and Dolores Huerta, where the phrase "Si se puede" originated. The participants in our study reported educating others about psychosis and mental illness, advocated for themselves, and even had family members advocate for them and their rights. It's important to think about how we can encourage adaptive coping strategies, such as empowerment. And from my own experience, I've seen the benefits of using empowerment strategies with Latinx families with children at clinical high risk, where much of our work, I think of like a particular family where much of our work was centered on empowering the family to advocate for themselves and the child. I saw that the parents educated their extended family members and gained the support and involvement of even their priest and other important adults in the child's life to come together. For this family, explicit discussions about disclosure and how to advocate were central to our work. So one possibility for our clinical work is that Latinx patients might be primed for interventions aimed at disclosure. There's been research on these interventions, and they show that they can reduce self-stigma, improve quality of life, foster social support and empowerment, and access to care. However, I want to highlight that there are many levels of disclosure. Some are listed here. They range from never disclosing to, in the middle, maybe disclosing taking medication that has some side effects. And then on the other end, disclosing one specific diagnosis and providing education to others. It's important to highlight that determining what is safe and what the individual is ready and comfortable with should be decided with the therapist or provider. So we're not promoting that everyone go out disclosing everything. And we should consider to what end will it be helpful for the patient. Ultimately, we want to encourage adaptive coping strategies, which can include empowerment strategies. I also want to point out that it's an evolving process, which should be attended to with their therapist and an ongoing conversation. And so this discussion, of course, inevitably leads us to thinking about anti-stigma campaigns. And I want to highlight that the findings on their efficacy have been mixed, and there's a conversation in the research on this. But I think a place that we can start is addressing provider stigma. Stephen Hinshaw, a major researcher in this area, has written about strategies that might be more effective to address stigma, and has suggested that we will need both top-down and bottom-up strategies. So addressing laws and policy that perpetuate stigma against people with mental illness and encouraging empathy, even among providers, is important, as well as improving training and identifying stigmatizing language that we use with our patients and with each other. And I have to take this moment to highlight research that supports the use of sport and physical activity as potentially less stigmatizing treatments. We see that exercise and sport are beneficial for the primary as well as secondary prevention of chronic illnesses in both physical and psychological domains. And the use of sport has also been found to increase treatment engagement. And then among clinical high-risk patients specifically, people are starting to look at this. Research has found them to be feasible, promote improvement in positive and negative symptoms, improve social and role functioning, as well as various cognitive domains. And in my own research, where I assessed the social validity of a sport-based intervention, the data showed that it is a socially valid approach, that it is seen as helping the patients, or the patients see it as helping them work towards their goals, have important effects, and is an acceptable method of intervention. No study, of course, is without limitations. So we point out that all of our participants were recruited in one clinic in New York City, which represents a subset of Latinx identities, and the Latinx community in the US spans numerous cultures. Prominent researchers in our field have critiqued the use of race in psychological research. And so again, we do not endorse using such categories to explain disparities. Rather, disparities in psychotic disorder diagnoses based on racial divides reflect larger social divides in access to care, resources, and lived experiences. And so we like to think of in terms of ethnicity. Previous research by some of our collaborators on this project has demonstrated that stigma among clinical high-risk patients is more due to the symptoms than the label itself. And so we didn't structure our framework in this way, so we can't outline these differences between ethnic groups, but is something to consider. And the aim of the original study was not directed to assess differences between ethnic groups, but all of the differences reported here emerged through coding and were naturalistic, thereby reflecting an unbiased reflection of these phenomena. So for providers, we think that it's important that you explore anticipated discrimination and stigma in Latinx patients and within the CHR population, and also assess coping strategies and bolster those that are more adaptive and supportive of mental health. This can include addressing secrecy safely, right? So if done, clinical high-risk individuals and their families may be empowered to educate and advocate for their well-being. And also consider interventions aimed at disclosure with, again, sensitivity to what is safe and appropriate for the patient. And that is the end of my presentation. Numerous references here.
All right. Well, I will applaud. Thank you. Thank you so much, Bernalyn, for a really, really fantastic and very thought-provoking talk. So I would love for everyone in the audience to, you can put your questions in the chat. Then I will go over them and review. We do have one question from Dr. Sano, which is actually a question that I was thinking about as well, which is, why do you think Latinx people are more likely to be diagnosed with a psychotic disorder? That was that came up in the beginning from some of the prior literature, 3 times for adults and twice as likely for children. So what do you think is the reason for that?
That's a really good question. And there's a lot of research on this topic, on disparities in diagnoses. And I think what comes to mind for me right now is research that I've seen more in looking at how Black Americans are more likely to be diagnosed with psychotic disorders. And from what I'm recalling, a lot of that has to do with provider bias. And interestingly, like their report of symptoms tend to be attributed to a psychotic process versus like a mood disorder. So it's interesting, but there's significant research out there on that.
Mm-hmm, mm-hmm. Right, and yeah, I'm aware of the literature and for Black Americans, and this was an interesting finding related to the Latinx population. And Dr. McCracken complimented you on a great talk, and was also asked if you could please explain Yang's finding that symptoms explain more stigma than the CHR label.
Yeah, so that is a good question. And also it was really interesting, and I was really excited, not excited, but I think it was a big development when this research came out in 2015. And yeah, explain the finding. I think what they were suggesting is that that the patients, that the participants, and as if I recall, because I helped conduct actually some of these interviews at the time, were just talked about stigma more about the symptoms that they were experiencing. So whether they were having interactions with people and experiencing symptoms, that was more stigmatizing than having the label itself. And so yeah, so the way that they talked about it was more directed at their symptoms that they were experiencing. And I think it's interesting, and it also kind of, I think, supports the work that we're doing in our clinics, that the label itself is not, because I think there was a discussion also when this was sort of a newer area around that it could be stigmatizing to and identify this group of people who have not been given a label before, and so what negative effects that might have on individuals. And so I think it's exciting to see that it's the symptoms that they're experiencing are more stigmatizing than the label we're given them. And the label also provides access to care and has really moved forward and advanced the research in this domain.
That makes sense. Yeah, I was thinking about that as well, as it's one of those issues that we really struggle with in terms of how to provide that feedback and whether that feedback is going to be helpful, for the person and the family. And then in fact, it's the fact that they're worried about disclosing the symptoms they're having as opposed to receiving this diagnosis. And the diagnosis itself, well, it's not really a diagnosis, but a label can actually give them some guidance as to what to do.
Yeah, exactly. And that's like what some of I think what's captured in the empowerment code is that, or the empowerment theme is that having the label, providing that direction and sort of knowing what to do can be, empowering.
Yeah, so a question from Dr. Laugesen. Have you or others looked at sex differences related to stigma?
We have not. I have not. And I'm scrolling in my brain if I've ever come across that. And it's not coming up as something that has been looked at. I'm sure maybe others have. I don't know, Carrie, if you have any knowledge about.
I can't think of anything specifically related to stigma, but it's an interesting question because I could imagine that, there would be differences in how you sort of how you internalize some of these, these feelings or discrimination fears, and whether there are differences in some of these strategies like covering, which may be more.
Yeah.
That would just be my hypothesis that women may tend to do more of that, but I don't know.
Yeah.
And we have a question from Dr. Addery, who thanks you for the excellent talk. And she says, you briefly highlighted clinician and use language as an intervention point for reducing stigma. Could you share any examples for practice?
Yeah. And this, I think, also is a point that was brought up by our own Dr. Gil Hoffman, who I, really appreciate, his feedback on that. And that, I guess the first example that comes to mind is what I referenced briefly in the presentation, and that in my own conversations with individuals of like Chinese culture, or who grew up in China, and there's a lot of research on stigma and in China and schizophrenia. So if anyone has that interest, you can let me know. It's very interesting. But in my own conversations, the individual expressed that the label itself is more stigmatizing because the label sort of doesn't really describe, or at least to their experience, didn't really describe what they were experiencing. So having a conversation more around, what are the symptoms that you're experiencing, and using their language to talk about the symptoms could potentially be not only just, a less stigmatizing approach, but also validating and just be more true to their experience.
Yeah, I think that makes a lot of sense. Question from Dr. Lord. Do you think results would be different here in Southern California, given it's a different Latinx population than Washington Heights, and maybe also a different non-Latino white population? So how important are these cultural differences within Latinx populations?
Yeah, that's a great question. And I think, just from my own experience, I grew up in California. I just spent all of my training before coming to UCLA on the East Coast. And I think there are some differences in the culture of just being in California versus being in New York City. But also a lot of similarities. I think Latinx culture, again, like highlighting that there are so many different groups that make up Latinx, right? And they have their own, they can differ. So it's already such a broad category that I imagine if you were to take a different sample elsewhere, might sort of be getting more individuals with different backgrounds. So for example, like in New York, you tend to get a lot more like, Dominican. I think in our sample, we had like Dominican, Puerto Rican, and Mexican. And so thinking about Southern California, sort of the general majority of the makeup, I'm not super familiar with, exactly what makes up the majority population in Southern California. I suspect Mexican, having grown up in California. So some differences in that sense, if that makes sense.
Yeah, I think probably more Mexican and Central American and less Dominican in general. Dr. Juliet Edgecombe also complimented your wonderful presentation and was interested in your thoughts on how to effectively adapt mobile and telehealth interventions for Latinx youth.
That is very exciting. I like that somebody's thinking about that. Let's see. I don't have, much experience with mobile and, well, I guess telemental health. We all have experience with telemental health at this point. But adapting mobile interventions for Latinx youth. I guess I would ask maybe a follow-up more specifically, more specifically what is in question about being that needs to be adapted. I'm a little bit lost as to where to,
Yeah, I guess having things in Spanish language would be one possibility. I'm not sure exactly what Dr. Edgecombe had in mind, but just from my standpoint, I don't know if there's also issues in terms of just for populations with fewer access to resources, like smartphones and things like that.
Yeah, an area that I have not researched much.
Yeah, but it's a great question.
Yeah.
And Dr. McCracken wonders if you think providers do develop unhelpful or stigmatizing attitudes from just the CHR labels, and if this is something that's been studied.
That's a big question. I think that's a big question. I don't know. And I think from my own experience, just having worked at various clinical high-risk clinics, from COPE to the Cedar Clinic in Boston and now here at CAPS, that has not been my experience. But also, right, I'm biased in that I've worked in these clinics. And I don't know if it has been studied. My suspicion is that it has not. If anybody's familiar with that, do let me know, because that is an interesting question. Like, what has been the effect of having these clinics, and what attitudes are the staff, I guess, taking on? Interesting.
Right. I can answer the second part, that it's not been studied much. And a couple questions that I would love to get to. We have just about 6 minutes left. To what extent do you think the qualitative method of this study, this is from Dr. Christopher Cacciolini, to what extent do you think qualitative methods of this study highlight these differences in coping that may be overlooked in more quantitative research? And what do you see as the next steps?
Yeah. So shout out, actually, this is one of our co-authors, Christopher Ciccolini. Let's see. Well, I think what I like about qualitative research is that I'm particularly very interested in like the lived experience of patients, and capturing, the nuance of, how they're experiencing their care, their treatment, whether their appropriateness, the acceptability of it. And I think that a qualitative method, I think allowed us to sort of highlight or let the data kind of speak to you, and sort of the patients making the themes instead of maybe us assuming that they're going to be using particular strategies, and we might not have captured empowerment. That was kind of like a interest that we did not expect to see that. So we might not have captured that if this had been a quantitative study. And next steps. Well, I think one important thing, and we've talked about, I think Chris and I have talked about this, is like, how do you encourage more adaptive? Well, first, like, what are the mechanisms, by which people are able to access more adaptive coping strategies? And then just like how do you do that? How do you encourage, other than, conversations and therapy, which I'm sure we're all doing, but encouraging those coping strategies would be interesting next steps, I think.
Yeah, and related, this is actually somewhat related, from Jared Greenberg, who also thanks you for a great presentation, and notes that, I'll try to summarize, this type of qualitative study is very good for identifying themes, as we discussed, and getting a preliminary impression of group differences, but not so good for determining group differences with a great deal of validity, given numbers, and at least partially. So have you considered using the identified themes to create a survey that could then be used to generate some quantitative data, including group differences, and maybe something, survey on a larger scale? This begs the question of whether knowing these group differences would lead to useful applications, and wondering your thoughts on that.
I think this is a great question, and just really that nice follow up to the previous question. But yeah, exactly right. That is something that I was aware of in putting together this presentation and trying to speak to, right, these are observations that we were made, and we cannot speak to, right, the numbers don't allow for like statistical comparison. And that's not really the point, right, of a qualitative approach. But yes, right, as they point out, these types of method can begin to direct us towards themes that might be important. And I would be very interested in seeing if we can put together, a survey that could generate some quantitative data. I think that would be a very useful next step. And then to their point about whether it could lead to useful applications. Well, I imagine and I would hope that it would just allow us to have a better, have a better sense of how to approach these conversations with our patients. Of course, everyone's experience is individual, and we cannot say that, we cannot say that non-Latino whites didn't use empowerment strategies. There was one individual who cited that, but I do believe it would still be helpful as providers to develop more culturally competent care, to have this knowledge.
Yeah, I completely agree with that, and I think it's really complementary to some of the more quantitative research that doesn't allow for these sort of open-ended themes to emerge, and really to allow us to generate new hypotheses about the experiences that people may have, and avoid some generalizations. So it's 10 o'clock. So I will think we should wrap up, but that was the last question we have. So I want to thank Bernalyn again for a really wonderful and very thought-provoking presentation, which is obvious by all the really great questions that you got. So thank you again, Bernalyn, and to everybody on the Zoom. I hope you have a wonderful and peaceful Thanksgiving holiday.
Yes. Have a great Thanksgiving, everyone.